Today we are going to present the student CPC from the Department of Orthopedics, and I will be covered by Dr. Rajesh from Department of Radiology, Dr. Alok from Department of Pathology, and Dr. Taruna from Department of Plastic Surgery, Bone and Plastic Surgery. Presenting the case of Mr. A, 11-year-old male, student and resident of Uttar Pradesh, presented to our AIIMS Rishikesh Ortho OPD on September 2021 with the complaint of progressive swelling in the proximal third of left forearm since 1.5 years, which is gradually in onset and progressive in nature, and also complaint of a pain in the proximal third of left forearm, which is gradually in onset, progressive in nature, non-radiating and aggravated on movement and relief somehow by rest and medication. And there is no history of significant trauma, no history of comorbidities, and no history of constitutional symptoms like swelling and on the other side, significant weight loss, fever, cough, abdominal pain, and bleeding from the orifice. And regarding the past history, in the birth history, that patient was born singleton by normal vaginal delivery from the primary mother at term and cried immediately after the birth, and no history of an ICU admission. And regarding the immunization history, that patient took all the immunization as per the schedule, and family, medical, and allergic history were insignificant. And in the past surgical history, that patient has the history of open surgery at the same site for the swelling on January 2021 at the elsewhere local center. And on the general examination, patient has the average build of height of 120 cm, weight of 37 kg with a BMI of 25.69. And on systemic examination, cranial nerve examination, cardiovascular examination, respiratory system, and the for abdominal examination were within normal limit. And going to the local examination of a left upper limb, that on inspection there was a globular swelling in the proximal third of a forearm of a 10 into 8 cm, and the extent of swelling extends from the 2 cm below the elbow to the 8 cm to the proximal wrist. And there is also healed surgical scar of 8 into 2 cm over the swelling, and there is absence of a venous prominence and the visible pulsation, and no open wound sinus or any skin changes or discoloration, and active wrist and finger movement was present. And on palpation, the swelling was well defined of 12 into 10 into 9 cm with a smooth surface, globular in shape, film to bony hard in consistency, and the swelling is attached to the underlying radius bone. It is free from skin, and swelling is non-tender. And there is also there was no local rise in temperature, no crepitus of the bony abnormality, and distal pulses were palpable. And regarding the range of motion of the elbow, that left elbow range of motion was slightly less than right elbow range of motion in the flexion due to swelling, and there was no any limb length discrepancy. And by this history and the clinical examination, my clinical diagnosis is aggressive bony swelling on the left proximal radius extending to the shaft of a left radius in a 10-year-old male. First differential diagnosis, I will keep osteosarcoma as the first differential diagnosis. Aneurysm bone cyst.
Need two others to give positive.
Okay.
Before you give your positive.
Okay. And osteosarcoma is the first differential diagnosis. Aneurysm bone cyst as the second differential diagnosis. Anyone from the house want to?
No, session is open to audience. So anyone like to ask questions or give their opinion about the differential diagnosis from the clinical presentation and examination can. Anyone from the residents ask questions? Differential diagnosis, which will come in your mind.
Pranav, what is your diagnosis? Loud.
No any medical therapy, just one surgical intervention was done over the swelling.
So you should discuss them like plastic, benign,
Yes, ma'am.
malignant, infectious. These are the possibilities. Any other conditions?
Yes, ma'am.
So what are
And on
actually
the
benign, it's 1.5 years history.
yes, ma'am.
Sarcoma is a very fast going to.
And next differential diagnosis, we can keep wing sarcoma is differential diagnosis, and we can also keep simple bone cyst as the differential diagnosis. And lastly, soft tissue sarcoma, we can keep soft tissue sarcoma at the differential diagnosis. And regarding the points in favor in osteosarcoma, that the swelling arises from the end of a long bone, that favors in point of osteosarcoma, and the swelling was aggressive, and age of the patient is in the second decade. So this point favored for the osteosarcoma. And regarding the aneurysm bone cyst, that patient is of a second decade, so it favors the aneurysm bone cyst, and the swelling arises from the end of a long bone, that also favors the aneurysm bone cyst. And since the swelling is aggressive swelling, that is points against the aneurysm bone cyst. And regarding the giant cell tumor, the swelling is aggressive swelling, that favors the in point of a giant cell tumor, and site of a swelling is in of a long bone, that also favors in point of a giant cell tumor. And as the age of a patient is less than 20 years, that is point against the giant cell tumor, since giant cell tumor is common in 20 to 40 years of age, with the female predominance, and sex of the patient is also male, so that is point against the giant cell tumor. And regarding the wing sarcoma, that shaft of a long bone is also involved, that favors in point of wing sarcoma, and age of second decade, that favors in point of wing sarcoma. But the end of a long bone, the swelling arises from the end of a long bone, that is points against the wing sarcoma. And regarding the simple bone cyst, that first to second decade of involvement, that points in favor of a simple bone cyst, and end of a long bone involvement, that also points in favor of a simple bone cyst. And since the swelling is aggressive swelling, that is point in against of the simple bone cyst. And as the swelling is aggressive, that points in favor of a soft tissue sarcoma, but on palpation, that was a bony hard swelling, that points in against of a soft tissue sarcoma, but it can also assist with the calcification of the soft tissue sarcoma. And origin from the radius bone, that the soft tissue sarcoma cannot be origin from the radius bone.
Regmi, what do you understand by this aggressive swelling? Every time you're writing aggressive swelling.
Sir, since
As ma'am rightly pointed out, the onset is 1.5 years.
yes, sir.
By history, you cannot call it as aggressive swelling. What makes you say it is an aggressive swelling?
That is point against.
No, ma'am, there are a lot of things point in favor of saying aggressive swelling, but I'm just wondering, because 1.5 hours, 1.5 years.
That is odd, no, for aggressive swelling. Aggressive swelling means a month or so.
There could be something in clinical examination which are hinting towards aggressive, being aggressive. Large size, is it?
Large size of a swelling, and also the tense and stretch skin. Yes, tense and stretch skin over the swelling, that points in favor of aggressive swelling, sir.
Something extra is rapid growth.
Yes, sir.
If it is rapidly growing in size, that points not towards. Has it been rapidly growing?
No.
Yes.
Yes.
Rapidly, the size of a swelling was onset of a swelling is since 1.5 years, and in 1.5 years the size of a swelling developed from 20 into 10 centimeter of size.
So after surgery, what happened to the swelling?
Swelling progressively increases after the swelling also, after the surgery also.
Some dissection of that swelling was
Yes, sir. Incision was given and some bony procedure was done, but that was undocumented.
I think a better word would be a low-grade malignancy
Yes, sir.
or an aggressive benign tumor. That would be my characterization.
Can it be infection by any chance? If I say it is tuberculosis.
Clinically, this last swelling cannot be associated with the infection, and on local examination also there was no tenderness over the swelling, and also there is no local rising temperature over the swelling, that points in against the infectious origin.
What about a chronic infection like tuberculosis? Tuberculosis can
But traditionally, infection is one of the differentials.
always a differential.
Yes, sir.
Always a differential.
And there was also no associated any discharging sinus over the swelling.
They are points against.
Yes, ma'am.
Thirdly, can it be trauma leading to some myositis, ossificans, or those kind of things, which can happen on both?
On history, there was no history of significant trauma as given by the patient. So after this clinical diagnosis, we want to go to the radiological diagnosis. Want to look for the radiology. I want to call Dr. Rajesh Rimal from the Department of Radiology to interpret this finding.
Good morning, respected. Also, I am going to present the radiograph. This is the lateral and AP radius. This one is the AP, and this one is the lateral radiograph of left forearms, showing both like elbow joint and wrist joint. Here we can see that there is it is a well defined. It is the expansile lytic lesion with radio opaque line within suggestive of the bony septa. Here we can see that the cortex is more or less intact, and there is no any periosteal reaction. There is narrow zone of transition, no any soft tissue component is seen within. Then it is eccentric image. So it is the and the lesion is involving the metadiaphyseal region, and the lesion is not extending to any of the adjacent joints. So it is here we have that eccentric expansile lytic lesion with bony septation and intact cortex. This comes with our radiological diagnosis of aneurysmal bone cyst, giant cell tumor, telangiectatic osteosarcoma, and Ewing sarcoma. And here in addition, I want to tell that there is no osseous matrix seen within the lesion. So for aneurysmal bone cyst, so it is here we have that multiloculated septate and metaphyseal origins, and so for giant cell tumor, here we have expansile lytic lesions, but since epiphysis is spared, so which goes against the favor of giant cell tumor. And for telangiectatic osteosarcoma, main feature is there, so we should have that osseous matrix, which is absent in this case. And favoring point is that metaphyseal regions, and against the other component, like there is no any soft tissue involvement, no any periosteal reaction. So these are also the point that against the telangiectatic osteosarcoma. For Ewing sarcoma, so the presentation of like this is rare for Ewing sarcoma. Point only favoring for this is diaphyseal involvement, and there's all rest of all are mainly against like say a septate lesion or no periosteal reaction. They are against the Ewing sarcoma. So to further characterize the lesions so to further characterization of the lesion, we go with the contrast enhanced MRI of the forearm. So here in T1 weighted image, we can see that there is the hypointense lesions with this showing their multilobulated. Here we can see that lobulations, and then within it we can see that there is T1 hyperintense fuse area of T1 hyperintensity within that hypointense lesions. And also there is the T1 hypo to isointense solid component within. So on T2 weighted image, we can see that the T2 hyperintense lesions, which is suggestive of the cystic lesions, and on the axial section, we can also see that there is the fluid level within. And so we have also done that contrast, which is showing the peripheral enhancement. Here we can see that there is the peripheral enhancement of the lesions is seen within. So considering this, we can now go with that narrowing the upper differential diagnosis to the aneurysmal bone cyst, giant cell tumor, and telangiectatic osteosarcoma. So for aneurysmal bone cyst, most of the points they are almost all in the favor of the aneurysmal bone cyst, like multiloculation, fluid levels, and there it is itself a cystic lesion and metaphyseal origin. And for giant cell tumors, like for all of the three differential diagnosis, the main point in favor is the fluid level, because fluid level are seen in all of them. So giant cell tumor, we can also see fluid level, and there is a small solid component, but it is not enhancing. So, and if in case of telangiectatic osteosarcoma, so one favor point is the location, that is metaphyseal, and another is the fluid levels. So point disfavoring that giant cell tumor, it is that if main point is that epiphyseal is dispersed and there is also no soft tissue component involvement and no marrow edema. And for also with the telangiectatic osteosarcoma, there is also no soft tissue component involved. So these are my.
After narrowing down our differential diagnosis from the imaging and radiography and the imaging, we did the core bone biopsy from the bony swelling under the fluoroscopy guidance, and we sent from the histopathology. And regarding the histomorphology of this slide, I want to call Dr. Alok from Department of Pathology to give opinion and differential regarding this slide.
Good morning, Director ma'am, Dean ma'am, respected faculties. So we received core bone biopsy, and in microscopy there is a blood-filled spaces lined by the fibrohistiocytic cells. These are the blood-filled spaces, and these are lined by the fibrohistiocytic cells, and there are also osteoclastic giant cells and variable bony tissue with the calcification. So aneurysmal bone cyst is our diagnosis, with associated benign and malignant tumors with the hemorrhagic cystic changes. So the giant cell is present in all these benign entities and also in the malignant entities. So in the giant cell tumor, we can differentiate with the aneurysmal bone cyst is that the giant cell tumor, giant cell is uniformly distributed, and in osteoblastoma there is clear osteoblastic sclerotic rim, and in the chondroblastoma there is chondroblast with giant cell is diffusely arranged, and in fibrous dysplasia there is septae which is in C or S shaped and with the Chinese pattern, and in telangiectatic osteosarcoma is the malignant differential, in which also the giant cell is present, but the cytological atypia and frequent mitosis is also seen in the telangiectatic osteosarcoma. So our final histological diagnostic criteria for favoring ABC is the multicystic lesion with fluid-filled spaces, cyst wall lined by the fibroblast and osteoclast like giant cell, hemosiderin pigment, and the new bone formation. We can also do the molecular studies like USP6 gene arrangement. This is ubiquitin specific protein gene that can upregulate the transcription factor NFK beta. These NFK beta can secrete metalloproteinases that will lead to the cystic bone resorption.
After getting the final diagnosis confirmation from the histopathology that we made the final diagnosis of aneurysm bone cyst of a left proximal radius, and from the clinical radiological and histological correlation that the points in favor of aneurysm bone cyst is the age of a patient is the first to second decade of a life, that points in favor of aneurysm bone cyst, and the location is a long bone with the metaphyseal origin. And on radiography there was an expansal lytic lesion with bony septation with the intact cortex. And in the imaging there was a multiloculated T1 hypointense and the T2 hyperintense cystic lesion with the fluid level. And on the histology that multicystic lesion with fluid space and the hemosiderin pigment was present, that points in favor of a final diagnosis of a aneurysm bone cyst of a left proximal radius. Looking at the aneurysm bone cyst, it is an active benign tumor that is locally destructive with the blood-filled reactive lesion of the bone. And site of lesion is most commonly affected. Site is proximal humerus, followed by the distal femur, followed by the proximal tibia, followed by the span and the other long bone. So, is our patient presented with a swelling on the forearm that it was slightly difficult to reach in the diagnosis, is the radius bone is not common to be affected for the aneurysm bone cyst. And in aneurysm bone cyst, the younger patient less than 20 years old affected with a slightly female predominance, and as the age of patient is male, so it was slightly unfavorable for making the diagnosis and is favor in point of our patient. And patient complain of a mild to moderate pain for weeks to several months. This finding is consistent with our cases. And regarding the diagnosis, I already discussed regarding the diagnosis by the radiograph, MRI, and the histology. And approach to the management of aneurysm bone cyst. First of all, patient will present to our OPD with pain and swelling on the affected part. Then we will go for the plain radiograph. And after the plain radiograph, we want to go for the higher imaging study like the MRI. And after the narrowing down the differential by the MRI, we want to go for the biopsy for the histological confirmation. And by correlating with this finding, if after making the diagnosis of aneurysm bone cyst, by correlating with this finding, if the lesion is small and non-aggressive lesion, then we can go for the lesser invasive technique like sclerotherapy, QRFC, and we can also perform the curettage and the bone grafting. And if the lesion is large and aggressive, then we can go for the excision and reconstruction. And regarding the lesser invasive technique, this is explained sclerotherapy by the modified Tesseri method, where we collect the 4 ml of sclerogen, that the polydoconal, with the 16 ml of air in the 10 ml of syringe, that is of 20 ml, and connect the all syringe to two-way parallel 3-way taps, and move the plunger of all syringe back and forth to make the sclerosing form, and the cycle is repeated for the 20 cycle. Then under the fluoroscopic guidance, we inject this sclerogen into the lesion. And let's see one case example, that patient was of 8-year-old male with expansor lytic lesion in the proximal humerus of a right side, and after injecting the sclerotherapy for the 3 doses, that lysis, there was a sclerosis in the lytic lesion with decrease in the symptom of the patient. And we can also go for the QRFC of the lesion, that while doing the biopsy, that the fluoroscopic guidance curettage of a lesion can be done by the lesser invasive technique. And this is the case example of a 16-year-old male presented with diagnosis of ABC of a left greater trochanter, and during the biopsy we also do the internal curettage of lesion, that is QRFC. Then after 3 months of the biopsy, that there was a sclerosis over the lytic lesion, that ABC can also yield by QRFC, that is the lesser invasive technique. And in our case, we plan to manage the case by the trial of sclerotherapy. We inject the 4 doses of interlesional polydoconal injection initially. At the time of presentation in the September 2021, patient presented with this X-ray where there was expansor lytic lesion with bony septate with the intact cortex. And after injecting the post cycle of a polydoconal in the January 2022, there was no subsidence of the swelling, but obviously we can see that some calcification over the septate lining, that is due to the action of a polydoconal sclerosant. And regarding the pre-op planning, in our case, if there was a large and the aggressive swelling, we planned for the wide excision. And after the excision of a bone, that obviously need the reconstruction. So for the reconstruction, we have 4 options. That we can use the autogenic bone graft. Tubular bone graft can be used as the stud graft, or 3 vascularized tubular graft can be also used in this case. And next option is that we can remove the proximal end of a radius, and there will be a single bone form with the ulna only. And next option is allogenic bone graft, but due to the limited stock of the such long bone, there was no ability of allogenic bone graft at that time. And we can also use the tumor process in such case. And among this option, the feasible option for us at that time was the vascularized tubular graft. And but after applying the vascularized tubular graft, that the main concern is the radiocapitular joint what to do for the radiocapitular joint. So for the radiocapitular joint, we have the option of a biological anconeus interposition arthroplasty, and for the limb length, is patient is of a growing age, and if we resect the proximal radius with the epiphysis, they will obviously affect the growth of a radius. Later, if there is variance in the radius and ulna, then we can plan for the epiphysiodesis of ulna. And regarding the wide resection and reconstruction, that bone autograft, this is the ideal method, early uptake, and can be used as the start of the vascular, and sometimes limited availability due to large gap. And regarding the bone allograft, that is limited availability, that might have the ethical concern, and disease transmission, delayed uptake, and but it will be the appropriate fit. And regarding the tumor prosthesis has a limited lifespan, need of customization according to the gap, and it is expensive. And next option we can have the extracorporeal irradiation followed by the reimplantation, where the patient own sterile bone will be implanted after removal and irradiation of bone by the 50 gyre for 15 minutes. And it needs no customization, but radiation insert tumor eradicated bone cell, but this was the so large swelling that we cannot reimplant that bone into the same place. And as the patient is of a pediatric age group, that in the pediatric age group it has the pediatric concern that it has the limited reconstruction option, and growth plate and the limb growth is also the main concern in the pediatric population. And as we can see this T1 weighted images, that radial proximal epiphysis, unaffected radial proximal epiphysis is only 3 mm. So while doing the wide excision, it is difficult to prevent this epiphysis, so we need to sacrifice the proximal radius epiphysis along with the tumor. And for the pediatric age group, vascular fibular graft is permission for the graft for reconstruction, and anconeus interposition arthroplasty will give the acceptable range of motion of elbow and the forearm, and epiphysiodosis can be planned to limit and regulate the limb growth of the ulna. By this it was elsewhere operated with the open surgery, that we made the final diagnosis of a recurrent aggressive aneurysm bone cyst of a left proximal radius, and procedure performed was in block excision of a tumor and reconstruction with the contralateral vascular fibular grafting and fixation with plating and anconeus interposition arthroplasty type 2 done on the 17th of February 2022. And it is the integrated effort from the Department of Orthopedics and Department of Plastic Surgery. And in intra, we approach over the swelling by the from the volar aspect with the line of incision, taking the previous surgery scar along with it, and we dissected the tumor with isolation of a radial artery, posterior interosseous nerve, and the radial nerve. As the posterior interosseous nerve was engaged inside the tumor, we have to sacrifice the posterior interosseous nerve intraoperatively. And this was the resected tumor specimen of 11 centimeter in size along with the radial head. And this was the indentation made by scallop margin of ulna due to the indentation of a tumor. And we reconstruct the extension digitorum longus intraoperatively, and we take the from the back of the elbow, we take the anconeus muscle flap for the interposition arthroplasty. And regarding the anconeus interposition arthroplasty, if we need to excise or remove the radial head, then it will obviously affect the radiocapitular joint and also the proximal radioulnar joint. So the biological favorable option for the after sacrificing the radial hedge is the anconeus interposition arthroplasty. It is of three types where anconeus flap will be elevated and attached with the excised with the reconstructed head of radius by making this by applying the anconeus flap over the radius, and in the type 2 we take the flap on the medial aspect and attach with this, and in the type 3 we round the anconeus flap with the head of radius, and in this case we perform the type 2 anconeus interposition arthroplasty. And this is the vascular fibular graft with the implanting over the proximal radius, and I want to call Dr. Taruna from plastic surgery to give
good morning, respected director ma'am, dean, academics ma'am, all faculty members and my dear colleagues. So I, on behalf of Department of Burns and Plastic Surgery, would be presenting the reconstructive part of the defect created as a result of wide excision of the radial bone tumor. As you can see, we have taken a free fibular vascularized graft with a skin pedal to reconstruct the defect created as a result of excision. The reason for using a vascularized bone graft was that the bony defect was more than 6 cm. So we took a vascularized bone graft, and we took a fibula as the bone because it can bridge up to 26 cm of the bony defect. And we did a peroneal artery and its veno-competitive vascular anastomosis with radial artery and cephalic vein. As we have harvested a fibular graft, there is acceptable donor site morbidity as well. And as a result, as you can see in the pictures, the post-operative result has come out to be very good. And the skin pedal, we use it specifically in a free vascularized bone graft for monitoring in the post-operative period of a vascular graft. Thank you.
And after doing the vascular fibular graft, we close the wound, and this is the post-op X-ray showing vascular fibular graft fixed with the DCP plate and maintained on the above elbow slab. And along with the tumor resection of a tumor specimen, we send the tumor specimen for the histopathological diagnosis, for making the final histopathological diagnosis after the resection of a tumor. And I want to call Dr. Alok from Department of Pathology to give opinion regarding the final histopathological diagnosis.
So we receive finally the globular bony specimen measuring 11.5 into 7.3 into 6.2 centimeter. The cut section shows the hemorrhagic fluid oozes out, and these are the hemorrhagic fluid oozes out, revealing a uniloculated cyst, and that is separated by the 10 wide cystic spaces separated by the thin septa measuring 2.5 into 1.6 into 0.9 centimeter, and the sections were taken and submitted in the 6 cassettes. So these are already told the high power of this. These are the giant cells. So these giant cells are differentiated from the giant cell tumor is that these are not uniformly distributed. These are distributed along the giant cell tumor. There is a giant cell which is distributed uniformly and of a regular size and is embedded by the mononuclear cells. So these are high power view. So by seeing these giant cell tumor is also seen in telangiectatic osteosarcoma, which is the malignant entity. But here the cytological atypia is not there, and there is no frequent mitosis is seen. So our diagnosis was the same as the aneurysmal bone cyst.
After making their diagnosis and being operated, the patient was on the 3 month of follow-up, and in the 3 month of follow-up, that patient has the acceptable range of elbow motion, almost comparable elbow range of motion in flexion and extension, and also the forearm range of motion at 3 month follow-up was almost comparable on the both side, with radiological union at the transition between the vascularized fibular graft and the remnant distal radius. but on later follow-up at the 9 month of follow-up that is we sacrificed the proximal epiphysis of radius, that there was a restricted proximal radial growth, but there was a normal ulnar growth. So patient developed the radial deviation from the left wrist region. That is a complication we observe on the follow-up period. That on X-ray there was a positive ulnar variance with a longer ulnar bone than the radius, and at the 9 months of follow-up the distance between the distal epiphysis of radius and ulna is of 10 mm. Surgery to correct the complication with the diagnosis of radial deviation deformity in the left wrist in the previously intervened case of ABC, left proximal radius with the wide excision and the contralateral fibular graft. The procedure performed was the epiphysiotosis of distal ulna epiphysis with the plating on 3rd of October 2022. And this is the fluoroscopic image. We applied the 8-sebit plate over the distal ulna epiphysis, making with the 2:2 in the one in at the epiphysis and one proximal to the growth plate. And this is the post-op X-ray after applying this epiphysiotosis plate. We maintain on the below knee slab, below elbow slab for the patient, and later at the 10 month of follow-up the patient again present to our OPD where distal epiphysis from the radius and ulna was initially it was of 10 mm and it was corrected, 2 mm was corrected, so it was of 8 mm at the 10 month of follow-up. And the final follow-up was done at the 12 month of follow-up. That distance from at the 12 month of follow-up, that distance from distal epiphysis of radius and ulna was only 4 mm, and patient had the acceptable range of motion with clinical correction of a radial deviation of the wrist. And regarding the literature review of the anconeus interposition arthroplasty, that it was a paper published in Journal of Shoulder and the Elbow Surgery in 2018 by author Rami et al. They included the 23 patients of the mean age of 41 years with the average follow-up of 38 months, and there was 18 patients with the native radial hair and 12 patients with the radial hair prosthesis. And while comparing the pre-operative and the post-operative DASH score, that is the disability of arm, shoulder and hand ratio, and the visual analog scale and range of motion of elbow and the forearm, that there was a significant improvement in all outcome. So it to conclude that from this paper, anconeus interposition arthroplasty performed after a radial head resection in the native and the prosthetic group is a viable adjunct in the operative treatment of the patient with post-traumatic radiocapacitor pathology. However, whether the anconeus interposition arthroplasty alone produced the favorable clinical result of this study was difficult to determine. And regarding the case we performed that vascular fibular graft and the anconeus interposition arthroplasty in a case of a recurrent aggressive bone aneurysm bone cyst of a proximal radius. We published a case report on the same in the Elsevier publication in 2023 only. And take-home message from this student CPC: the clinico-pathological correlation for the final diagnosis is essential, and the oncological free margin is the primary aim of tumor surgery. We can, after sacrificing the vital structure also, and the growth plate should be respected in the pediatric cases, and vascular fibula offer a permission graft from the long bone reconstruction, and biological anconeus interposition arthroplasty achieves an acceptable range of movement of the elbow and the forearm. Thank you.
Yes, anybody about those questions regarding the case?
Dr. Anil,
Yes, sir.
I have two questions. First question is, what happened to the PI and palsy? said that there was a sacrifice of the
Yes, sir.
posterior trochleus nerve.
Yes, sir.
So what did you do?
Sir,
Can you go back to the intraoperative picture?
yes, sir. Sir, after sacrificing the posterior interosseous nerve, we reconstruct the EDL and
You reconstructed what?
EDL.
Extensor digital longus.
Yes, sir.
With what?
We did the
Actually, the posterior trochleus nerve, when it had entered the tumor, it had given the branches to the extensor policies. So we had noticed the extensor digitorum to the extensor policies. So he has extension of the digits are still there, but yes, it is not to the maximum, but yes, extension is still there. Yes. So the branch was to extensor policies was given before entering into a tumor. So we have saved that.
My another question is, what is the added advantage you have got by doing a vascularized fibula graft instead of a non-vascularized one? Because you have extended the operative time of the patient.
yes, sir.
And you may not have required plastic surgeon's help if you have gone for a the non-vascularized one. So why you have specifically gone for a vascularized one?
Sir, optic, there is the good optic after applying the vascular fibular graft compared to the stud grafts, sir. And union also will be earlier.
So actually, the seeing that if we take a length of fibula more than 7 centimeters, so that it becomes very difficult for it to get a vascularized. So if we have to resect a tumor more than 7 centimeters, we should go for a vascular fibula graft. So in this case, our tumor was more than 8 centimeters, and we resected a margin of approximately 11 centimeters. So we opted for a vascular fibula graft.
Okay, my question to Dr. Akshay, please. So why you didn't choose an epiphyseal graft instead of a normal vascularized fibula graft? Because if you have taken the epiphyseal growth plate along with the fibula, so probably you may not have required the distal epiphyseal disease of ulna. So what are your thoughts on this?
So when we're taking the epiphysis of the fibula, the chances of taking monitoring pedicle paddle are next to nothing, because there are no perforators going from the anterior tibial artery to the skin paddle. So one of the problems of taking the head of fibula is that you have to anastomose the anterior tibial artery and the vena comitans of that. Second, obviously there are no perforators going from the anterior tibial to the skin which can be captured, so we cannot monitor whether the transplant that has been done is actually working or not. Third, the injury to the peroneal nerve becomes much more significant when we are taking the head of the fibula. So it is something that the chances of deformity to the patient are more. So even when we give this option to the patient, he does not actually give consent for accepting the foot drop, because the chances of foot drop are much higher as compared to taking the only the diaphysis of the fibula, which is done with the peroneal artery. So these are the concerns which I actually discuss with the patients, and we have to take the consent for it.
Thank you.